Hello and welcome. My name is Jordan and I will be the moderator tonight. We'll be debating on whether ABA is ethical or unethical, using a formal debate format. Our pro-stater, Kim, will begin, then we'll go to Christina, our con-stater, followed by myself, the pro-prover. We'll then hear from our con-prover, Christina, followed by Ashley, our pro-attacker, and Liz, the con-attacker. We'll hear back from our pro-stater, Kim, and then our con-stater, Christina. After this, we'll have questions by Ashley and Kim. We're going to get started with Kim, our pro-stater now.
Applied behavior analysis, or ABA, is defined by Cooper and Heron as the scientific approach for discovering environmental variables that reliably influence socially significant behavior and for developing a technology of behavior change that takes practical advantage of those discoveries. The basis of ABA was first developed in the mid-1900s after the findings of B.F. Skinner. Years later, Bayer, Wolf, and Risley published an article titled Some Current Dimensions of Applied Behavior Analysis that currently stands as the backbone to the field. In the article, it lays out 7 different dimensions that behavior analysts must follow in order to evaluate a study or a behavior. Behavior analysts in the field of ABA don't simply pick behaviors that are easy to study, but rather ones that are socially significant and are in excess. Even though the Bayer, Wolf, and Risley article was written decades ago, and as behavior analysts we still strictly follow those guidelines, we have still grown as a field. Much research has been done throughout the years, and through that, the field of ABA has significantly changed for the better. In January 2016, an updated version of the Professional and Ethical Compliance Codes for Behavior Analysts was put out by the BACB. In doing so, the BACB is continuing to modernize and improve the codes to better support clients, supervisors, supervisees, etc. On the pro side of the argument, we will be arguing reasons as to why we believe that ABA is an ethical field of practice. In the debate, we will discuss how ABA uses evidence-based treatments that can decrease maladaptive behaviors and increase verbal, social play, and adaptive skills that are deficient. A hot topic that is always brought up against the ethical treatments used in ABA is the use of punishment. During our argument, we will define our use of punishment and give examples as to what procedures that are put into place when punishment is used. Lastly, we will talk about some of the benefits of partaking in ABA treatments and even give some firsthand parent feedback on how applied behavior analysis has helped their child.
Now we'll be going to our con-stater, Christina.
Applied behavior analysis has historically been criticized for having questionable ethics. Examples cited often involve treating individuals with autism like animals being trained for performance, turning children into robots by having them provide rote answers to specific questions, and using extreme aversive procedures as deterrents to behavior deemed inappropriate. The argument in this debate will focus on the questionable ethics of ABA in regards to procedures for informed consent, the use of punishment, specifically in regards to aversive procedures, and the ignorance of those working in ABA to the neurodiversity movement.
Moving on to myself, the pro-prover. The U.S. Surgeon General has said that ABA is the only treatment for autism that is scientifically validated. Besides the U.S. Surgeon General, other organizations have also publicly suggested ABA, such as the American Association of Pediatrics, the American Speech and Hearing Association, the Autism Society of America, and the American Psychology Association. Cooper, Heron, and Heward also said that ABA is a scientific approach that offers scientific support methods to increase positive behaviors in those with autism, as well as reduce behaviors which can be harmful, such as tantrums, which could also impede learning in a classroom. Aside from being scientifically validated, ABA is also kept regulated under Public Law 194-142, otherwise known as IDEA, Individuals with Disabilities Education Act. This law governs services such as ABA provided to those with special needs. Under this law, ABA is only given when necessary as well as only implemented with the consent of the child or a legal guardian. Treatments given also must be done by a competent behavior analyst, and the most effective but least intrusive treatment must be used. BCBAs must follow Public Law 104-191 as well, also known as HIPAA. This law protects the confidentiality of the clients receiving ABA. Ethical guidelines in place are also visible on the BCBA website. These include Ethical Code 101.1.0, Responsible Conduct of a Behavior Analyst, which says that they must maintain professional standards. 1.01, the reliance on scientific knowledge. BCBAs must only practice using scientifically derived knowledge. 1.02, BCBAs must only practice within their professional boundaries in areas which they are competent. Later on, down the line, 1.05, which also implements the professional and scientific relationships between the BCBA and the client. Aside from the ethical guidelines are the core ethical principles that BCBAs must follow when doing ABA, which include do no harm, respect autonomy, benefit others, be just, be truthful, treat the client with dignity, treat others with competence, pursuit of excellence, and accept responsibility. With the legal guidelines in place and ethical guidelines, along with scientific validation, ABA must be ethical. Next, we will hear from our comprover, Christina.
First, I would like to discuss the issue of informed consent in ABA. Informed consent means that all clients or participants in a research study agree to all treatments, interventions, and procedures that will be used, and that they are made aware of all potential risks involved. The Professional and Ethical Compliance Code for Behavior Analysts has several codes related to the importance of informed consent, including Code 2.05, Code 4.02, and Code 4.04. These three codes stress the importance of clients' legal and provide written consent for behavior change programs. It is often found that informed consent may not come from the actual person on the receiving end of the treatment, but a party acting on their behalf. In these cases, it is usually a parent or legal guardian providing informed consent for the behavior change program. It has also been argued that applying ethics to autism research and actually receiving consent from the individual actually receiving the treatment would be detrimental to not only autism research, but also to individuals with autism. An example of this is seen in a 1999 spring newsletter for the Association for Science and Autism Treatment. It reported about a mother who testified in front of the U.S. Bioethics Committee, arguing that informed consent from parent and legal guardian should be sufficient. However, this goes against the previously mentioned BACB ethical compliance codes. It also violates the core ethical principles of respecting autonomy and being just. Ethically speaking, shouldn't a person undergoing the interventions and procedures laid out in the behavior change program be the one that should provide informed consent? If behavior analysts ignore that individual and only require consent from parents or legal guardians, we are not promoting the individual's independence and ability to make their own decisions, especially if they are adults, and we are not treating them the way everyone else is treated. A second point I would like to make on the questionable ethics of applied behavior analysis is the use of punishment, specifically the use of aversive stimuli. In 1974, Reckers and Lobos published a study titled Behavioral Treatment of Deviant Sexual Behaviors in a Male Child. In this study, Craig was a 4-year, 5-month-old boy referred to the researchers by his mother because he liked to wear girl clothes, play with makeup, and he didn't engage in typical rough and tumble play with boys because he was afraid of getting hurt. To decrease the unwanted girl-like behavior, the parents were taught to use various punishment interventions. Reckers and Lobos noted that spanking Craig was the most effective punishment in bringing about change in his behavior. At the end of the study, the researchers noted that people who saw videos of Craig before the study and after the study stated it was like watching two different boys. Craig took his own life in 2003. In 2011, CNN conducted an interview with Craig's family. The family recalled the spankings as severe and frequent, often leaving welts and affecting Craig emotionally later in his life. Craig's mother stated that she now believes that the involvement in the Rikers and Lovaas study destroyed her son's life. Of course, some may argue that this study occurred in 1974, and procedures that were deemed acceptable then are clearly not acceptable now. This is not the case. Punishment in the form of electric shocks has been used at the Judge Rotenberg Educational Center in Massachusetts. Here, students are attached to devices that deliver electric shocks when a staff member simply pushes a button. The center has stated that they use the shocks only when positive behavior support interventions have failed, and when a student engages in severe forms of aggression that will cause harm to themselves or others. However, there are many reports of shocks being used without any type of positive interventions in place. There are also reports of shocks being used for behaviors including refusing to follow a direction, slouching in their seat, getting out of their seat, and refusing to take off their coat. These behaviors are not examples of severe forms of aggression, and they are not life-threatening. Many individuals and parents are speaking out against the use of shocks at the JRC. Jennifer Masumba was treated at the center and recalls receiving 5 to 10 shocks for one behavior, and that she would often wish she would die because she did not want to live while being shocked. She also stated that she felt like she was being punished for being disabled and for even being born. Cheryl McCollins described watching the videotape of her son Andre being shocked more than 30 times in a 7-hour period. Mrs. McCollins believes Andre was shocked for refusing to take off his coat and for crying out in pain from the shock. Mrs. McCollins describes Andre's treatment at the center as torture and abuse, and feels that her son has suffered permanent damage as a result of his stay at the Judge Rotenberg Educational Center. Disability advocates have also been fighting the use of shocks at the center for many years, stating that it goes against everything known about the science of behavior change. It was also argued that parents would be arrested if they employed the interventions used at the center. The use of punishment at the Judge Rotenberg Educational Center and in the 1974 study, published by Rikers and Lovaas, violates many of the core ethical principles, including do no harm, benefiting others, being just, being faithful, according dignity, and treating others with care and compassion. The use of punishment not only violates most of the core ethical principles, it also violates many of the BACB professional and ethical compliance codes. Most importantly, codes under 4.08 describe conditions regarding punishment procedures. In summary, codes 4.08A to 4.08C state that reinforcement procedures should be recommended and used before punishment. Code 4.09, which states that the least restrictive procedures should be recommended, is also violated in the examples of the Rikers and Lovaas study and the treatments of students at the JRC. Previously mentioned codes are also violated, including Code 2.05A, Code 4.02, and Code 4.04, which stress the importance of the legal rights of clients and that they should be involved in the development and provide written consent for their behavior change program. The final point I would like to make in regards to the questionable ethics of ABA involves the consideration of the neurodiversity movement. An article titled The Autism Rights Movement in the New York Magazine describes the neurodiversity movement as one that is made up of individuals with autism and their families or caregivers that believe autism is not a disease to be cured. It should just be seen as a different way of functioning. Historically, autism has been looked at as a disease. Referring to the article, The Misbehavior of Behaviorists, Michelle Dawson takes issue with the idea of individuals with autism being seen as less than human when compared to individuals without autism. Dawson states that proponents of ABA feel that if you are against ABA, you are for institutionalization, that autism is incompatible with humanity, and if an individual with autism is deprived of ABA, they are doomed. Dawson argues with the notion that individuals with autism need to be changed so that they act like everyone else. The neurodiversity movement also argues that individuals with autism should not need to be indistinguishable from everyone else. For example, many people with autism engage in essentially harmless self-stimulatory behaviors, such as rocking, hand clapping, humming, spinning, etc. Typically, behavior analysts will attempt to decrease or extinguish this behavior in essentially an attempt to make the individual with autism look and act like everyone else. However, what we all engage in some form of self-stimulatory behavior. Maybe instead of hand flapping, we crack our knuckles, and instead of rocking, we shake our leg. The self-stimulatory behaviors of individuals without autism are only taking on a more acceptable form, but are essentially serving the same function as those with autism. The Socially Anxious Advocate is a blog that states that the issue with goals to decrease self-stimulatory behaviors completely discounts the fact that everyone has a reason for doing something. It also pointed out that these behaviors often serve the function of assisting the person with autism to manage overwhelming sensations. It can be argued that trying to make individuals with autism indistinguishable from those without autism violates the following core ethical principles: respect autonomy, benefiting others, being just, and treating others with care and compassion. Many professional and ethical compliance codes are also violated, including codes 2.05a, 4.02, and 4.04, which state that the client's legal rights are of the utmost importance and that clients must be involved in the planning, development, and provide written consent for the behavior program. These are just a few examples of the questionable ethics in treatment practices and applied behavior analysis. Those who work in ABA have attempted to ward off unethical behaviors with the application of the 4 ethical principles and the professional and ethical compliance codes. However, as seen in just these few examples, the core principles and compliance codes can easily be violated.
Thank you. All right. Next, we will hear from our pro attacker, Ashley.
Thanks, Jordan. Again, my name is Ashley Lehman. I've been working in the field of applied behavior analysis for approximately 3 years. I've had the privilege to work in in-home settings, in school settings, and I'm currently in a clinic setting. I was also very fortunate to receive supervision from a BCA who came to work every day to work herself out of a job. With that being said, she worked with the intent to increase socially significant behaviors and decrease dependence upon another person. So with this in mind, throughout my experience as an ABA interventionist, a true foundation for ethically sound practice was instilled early on. So when dissecting ABA further from multiple perspectives, there are many viewpoints we have to analyze and plan to help our clients adapt to. We have the teacher's perspective if there's a school setting as well as ABA intervention. There's other disciplines such as occupational therapy, physical therapy, speech therapy, feeding, all domains in which you have their own histories as well. But most importantly, the parent's perspective and or client's perspective is what we have to really focus on. And then there's us, right? The behavior analysts. These multiple perspectives allow for many challenges as well as growth. I'd like to pull a few examples from our readings from Bailey and Birch, How to Think Like a Behavior Analyst, and also I want to talk about Cooper's definition of what it is applied behavior analysts do. So from How to Think Like a Behavior Analyst, the preface actually states, behavior analysis has often been described as the best kept secret in psychology. As a well-established evidence-based treatment approach based on learning theory, behavior analysis has been making a significant difference in the lives of many thousands of developmentally disabled individuals for 40 years. Behavior analysis procedures have been developed to teach basic self-help skills, functional language, and community access repertoires to individuals with disabilities and to allow them to live and enjoy rich and varied lives. Now going to Cooper's definition, I'll just read the shorter version. Applied behavior analysts focus on objectively defined behaviors of social significance. So these definitions in comparison to the neurodiversity movement that Christina mentioned earlier have really turned heads for quite some time. Cooper, Bailey, and Birch discussed what ABA was founded upon. And over time, we have evolved as a field and have currently come to the conclusion that there is no cure for autism. Autism spectrum disorder is a lifelong disorder that an individual may face, and within that comes specific characteristics. These characteristics, a few Christina also named, were hand flapping, spinning, rocking, and these characteristics become a part of an individual's identity. This often can be controversial when addressing the self-stimulatory behavior, only if it's impeding on one's ability to function independently. Do we decrease the self-stimulatory behavior? Do we allow participation? If so, how often? Many questions arise from this topic, and our BACB Code of Ethics do a really nice job of addressing it. A few examples being 2.01, accepting clients, 1.04, integrity, 2.05, rights and prerogatives of clients, 2.09, treatment intervention efficiency. These codes, paired with our core principles that go back to Cooper, Bailey, and Birch, pinpoint that both of these combined combat this ongoing discussion with its definitions and the repetitive use of phrases case-specific and social significance. Given our shortly evolved field paired with the sensitivity of our treatment, analyzing exactly what ABA intervention is and does through a legal guardian's perspective is one of the most important factors for successful treatment outcomes. It is easy to see an unethical point of view if there is a breach within the professional in charge of the BIP or ITP. For Craig's specific case that Christina mentioned previously, Craig's mother was absolutely correct when stating ethical violations were made. That I've witnessed as well. For example, when I first transitioned to the clinic setting 2 years ago, I was assisting with a severely aggressive older male whom engaged in intentional avoiding, tackling, hitting, kicking, etc. And one of these intense scenarios, this patient's SPCE turns to me and says, "What do we do now?" And dumbfounded, afraid, and confused, I decided that in this moment that having a credentialing to your name, BCBA, didn't necessarily always mean best practice was being implemented. These unfortunate examples, my experience, Craig's life, the treatment provided at the Judge Rotenberg Center are also a few of the exceptions. Given that the publication of the Riekers and Lobos study was in the year of 1974, and the report I gave to my corporate headquarters post the experience with that BCBA, as well as the resigning of Dr. Matthew Israel, founder of the Judge Rotenberg Center, it's because of these actions along the way that significant growth has been accomplished within the field of applied behavior analysis. These accomplishments ranging from the creation of the Behavior Analyst Certification Board established in 1998, increasing the required credentialing to become a BCBA, increasing the required amount of CEUs needed to stay certified, creating the registered behavior technician profession in order to implement that ethically sound high standard of practice, setting the 5% rule for supervision, and ultimately these instances are why the BACB Code of Ethics exists. When a person is exposed to a behavior analyst or psychologist or teacher who implements behavior analytic principles, whom also does not abide by the BACB Code of Ethics, distasteful and repulsive stigmas towards the field of ABA as a whole are created. The example I mentioned earlier, suicide, could have been prevented if there were a credentialed, ethically sound, abiding professional in charge of the ABA intervention. This ABA intervention that I speak of being ethically sound, high standard of practice includes appropriate prompt fading procedures, gauging what the right amount of DTT, discrete trial training sessions are, versus NET, natural environment training sessions, utilizing shaping, excessively implementing positive reinforcement strategies, and lastly, utilizing punishment procedures only when all other intervention options are exhausted. I have presented everyone with this graph. This graph was published by the National Professional Development Center on Autism Spectrum Disorder and was created in November of 2017, so only 5 months ago. It is the comparison of evidence-based practices that are proven effective with current published research in relation to the intent of your goal. So what this looks like is, to your left, you have different evidence-based practices such as antecedent-based interventions, cognitive behavioral interventions, DTT, exercise extinction, all while being alphabetically ordered. How nice. With the intent of your goal being, so what is it that you're targeting? Are you targeting social skills? Are you targeting communication, joint attention, specific behavioral patterns? All while it presents with the age. So, for example, if you're planning to utilize PECS, Picture Exchange Communication System, when targeting communication for the ages ranging from 15 to 22, if you look on here, it shows that further research and consulting needs to be done because there is no current evidence-based practice matrix available. It is crucial that as behavior analysts and interventionists, we are adhering to Ethical Code 2.11, records and data, and utilizing our resources and referring back to the evidence-based practice interventions proven by research, especially when implementing those punishment procedures. There are evidence-based practices out there that provide us with ethically high standards of treatment that we as professionals are obligated to seek out and research. And if we do not, there are consequences, as there should be. There are legal and ethical violations that appear when working with undertrained professionals, these being revoked licensure and even jail time. Given ABA's short history, there are going to be obstacles, barriers, but most importantly, change. There are other medical professions that have been around much longer than ABA that have come with their own immoral and unethical practices. For example, if you've been keeping up with the news, there's the Dr. Larry Nassar case, whom has practiced as a medical physician for over 30 years and was also just recently on patients. So there are going to be different obstacles that come with each field, no matter the history, and it all is dependent upon the nature and the motivation, the intrinsic motivation of the professional in charge. Like I said before, ABA may have a short-term history and come with growing pains, but ABA is the most up-to-date scientifically proven treatment to aid those diagnosed with autism spectrum disorder. Therefore, this is what behavior analysts and families in need should and will seek until science says otherwise.
Thank you, Ashley. Now we'll hear from Dr. Lee.
Azrin and Hulse defines punishment as a reduction in behavior due to a consequence made contingent on the performance of that behavior. In 2008, Reed, DeGeneiro, and Lovett decided to randomly select members from the 2004 online membership of the Association of Behavior Analysts to find out how practitioners really feel about punishment-based procedures. Am I echoing you guys? Okay, just checking. Respondents were asked to respond with agree or disagree with statements about punishment using a 6-point Likert scale. The first graph shows the respondents' views of the efficacy of punishment. These 3 statements were all surveyed as slightly agree to agree on the Likert scale. The statement, punishment has more negative side effects than positive reinforcement, received an average score of 4.8 on the Likert scale. The statement, many supposedly non-adverse procedures actually have components that rely on adverse stimuli, received an average of 4.5 on the Likert scale, or slightly agree to agree from the respondents. Positive reinforcement is more effective than punishment at changing behavior, received an average score of 4.2 on the Likert scale from the respondents. The second graph shows the respondents' views on the ethics of punishment. All 3 of these statements were surveyed by practitioners about how they feel towards the following statements. Punishment should be reserved for behaviors that pose a danger to the individual or others, received a score of 4.9 on the Likert scale from all respondents. As long as the Behavior Management Committee approves of punishment procedure, it is ethical to implement, received a score of 2.5 on the Likert scale, or slightly disagree to disagree from the respondents. Punishment is appropriate as long as the consent is obtained, received an average score of 2.5 on the Likert scale. Going off the idea of consent, we go back to the Code of Ethics that Christina talked about in her argument. Ethics Code 2.05a, the right of the clients are paramount in how behavior analysis support clients, legal rights, and prerogatives. I would argue that just because the client consents to a treatment does not necessarily mean that the treatment is ethical. There are adults with autism out there who are their own guardian, and just because they can sign a piece of paper does not mean they are able to fully grasp what is happening. They don't know their legal rights, so it's our job to advocate for them to ensure their rights are being protected. I work with an individual who their family isn't in the picture, they do not have a county official, And it's one of those things where if someone were to want to conduct a functional behavior assessment or maybe try to adjust one of their behaviors, it would become ethically questionable because he is nonverbal, his IQ is below 70, his verbal communication skills are pretty much non-existent. So in their case, I would not feel comfortable doing something like that because I cannot say without a reasonable doubt that he is able to understand what is going to happen and understand what he's consenting to. Ethics Code 2.05D, clients and supervisees must be informed of their rights and about procedures to lodge complaints about professional practices of behavior analysts with the employer appropriate authorities in the BCBA. When clients are not giving informed consent, they are also not aware that at any time, if they feel their rights are not being upheld, they do have the right to lodge a complaint against the practitioner. The same goes for a parent if they do not feel that their child's rights are being upheld, or they feel that the practitioner is acting unethically or inappropriately. Ethics Code 4.02, involving clients in planning and consent. Behavior analysts involve the client in planning and consent for behavior change programs. If the BCBA does not inform the parent and client in what will take place as a form of punishment within a behavior change program, then they are in violation of the Code of Ethics. It is their responsibility to be clear as to what the punishment will look and feel like, so fully informed consent can be made. Applied behavior analysis is notorious for replacing behaviors we consider to be negative. Then we have to ask, well, what is considered negative behavior? Obviously, any behavior that is putting the client or any other person in physical harm or at risk is considered to be a negative behavior. But what about self-stimulatory behaviors? There is no place where it is determined that behavior A is negative, whereas behavior B is not, which leaves a little bit of room for discrimination. One BCBA might think that this client's hand flapping is a negative behavior, while another BCBA might feel that it's not necessary because the hand flapping acts as a calming mechanism, so they don't address the behavior. But then we ask, why is it a negative behavior? Is anyone around them being harmed? Are they harming themselves? Is it because it looks different than my personal calming mechanism, which is taking deep breaths? Some advocates believe that ABA wants to change these behaviors because they are visually more acceptable to the public. That is, they want to change a behavior that they consider to be negative because it is not deemed to be normal. This then puts you in violation of another core principle of ABA, which is respecting autonomy and being just. These behaviors put no one in harm or danger. They are being changed or punished because they look different, and that's not fair.
Thank you, Elizabeth. Now we'll hear from our pro-stater, Kim.
Everyone goes into this field with the same goal of helping and improving the lives of those we service and their families. Each day we go to work, we are trying our hardest to work ourselves out of a job with the hopes that our clients don't need us anymore. In the field of ABA, the professional and ethical compliance codes for applied behavior analysis is heavily stressed, and the first section in the code is strictly about responsible conduct. As Ashley stated in her argument, there are those who don't follow the ethics code to a T, but those are the behavior analysts that need to be reported, as written in Compliance Code 7.02. It is not fair for colleagues to have to implement inappropriate treatments, especially if they are unaware of the compliance codes. But most importantly, it is unfair to the clients that they serve, having someone that they care and trust implementing treatments and procedures that are not acceptable by the BACB. When it comes to consequences for behavior, ABA stresses using the least restrictive procedure and exhausting all other avenues before implementing a more intrusive treatment, which may include our definition of punishment, presentation of a stimulus immediately following a response, which decreases the future rate or probability of the response. Lastly, I want to leave you with a quote from a parent that provides an insight on how ABA changed their relationship. I think he has a really great relationship with me, his mother, which I really don't think he would have had if he stayed at school. I would have been the person who picked him up, took him home, and put him to bed, whereas I think it has helped for both of us to bond together.
Thank you. Now we'll hear back from our prom stater, Christina.
Treatment procedures used in ABA can often involve questionable ethics. Of course, proponents of ABA employ the professional and ethical compliance codes and the core ethical principles in an attempt to ensure that behavior analysts are acting ethically in their treatment. However, it can be seen that just because these standards exist does not mean that violations never occur. A common argument that is made is that ABA is a young science and mistakes will be made and corrected as time passes and the field grows. However, consider the cost of those mistakes. Think about Craig and his family from the Reckers and Lobos study. Craig took his own life, and his family now carry a huge burden. Think about the students who are speaking out against their treatment at the Judge Rotenberg Center and how it must have made them feel to be physically harmed for engaging in a non-life-threatening and non-aggressive behavior. Unfortunately, there are several similar stories due to practices of ABA. Perhaps it would be beneficial to the science of ABA to further their research into the necessity and ethics of punishment procedures. It would also benefit the practice of ABA to actively involve the individual actually receiving the treatment, not just their parents or guardians, into the planning and consent process. Finally, if those who work in the field of ABA opened up to the neurodiversity movement and saw the individual with autism as their own person and not someone who needs to change to become indistinguishable from those without autism, this would help to advance not only the science of ABA, but its ethical standards as well.
Thank you, Christina. Now we'll move on to our questions.
So the questions were, what guidelines would you recommend parents to use to determine if 40 hours of ABA are really needed? And then, what if insurance won't approve it? And then also, what if you recommend 40 hours and a family is only willing to do 10 to 15 hours? What are the ethical considerations that come with this? So as far as guidelines that I would use or recommend to parents to determine if 40 hours of ABA is necessary, I would definitely suggest that they do a file review with the BCBA, just looking over their medical status, prior assessments that have been conducted before, as well as their results, how they've responded to any prior treatments that they've received in the past, intellectual achievement tests, if they've done any, if they're old enough, otherwise just any developmental delays that they may have noticed so far. Then once that has been reviewed, I'd suggest a direct assessment be done. Direct observation and data collection can determine pre-treatment levels of functioning, as well as development and social interactions. Observations of those can kind of determine how many hours should be needed. It is advised, though, that more time away from therapy may result in the client falling further behind than they already are. And obviously, one of the things with ABA is early intervention. So kind of the sooner you get them in with the more therapies, the better. And then if you were to do 40 hours, it is ideal to slowly work up to 40 hours just to build the tolerance of the long hours. You would never want to start a student at 40 hours from scratch, just because they might result in them having more behaviors just because they're not used to being in therapy for so long. So it would be one of those things where you'd want to slowly build up to 40 hours. As far as insurance, if they won't approve it, I would suggest that using hard data just to prove to them, like, this is why I think we need it. If a functional behavioral assessment hasn't been conducted, to conduct one, or functional analysis, just depending on what your clinic uses. ABC data, if you have it, any assessment results that have already been done, indirect assessments, direct observations. Just build your case towards the insurance to prove this is why I think my child needs this amount of ABA, and this is the benefit I hope to receive from it. And then we go back to, well, what if I recommend 40 hours and a family is only willing to do 5 to 10 hours? And the ethical considerations come with that. You have to consider that family comes first. If a family generally comes to you and says that they have 4 kids at home, that doing 40 hours of ABA is just not happening. It's not practical with their lifestyle. You have to respect that. Obviously, you can provide them with information as to why you think the 40 hours would be most beneficial. But if they're set in their ways on not doing 40 hours, the best you can do is make the best of the time that you have. If they're only giving you 10 hours, see what best treatments that can be most effective in a short amount of time.
We were asked, are there times when ABA would not be the best treatment, and are there other therapy modalities that you might recommend? Our answer was yes. Given a certain individual's intellectual, physical, or mental ability, ABA might not be the best fit. One of these examples being when one individual may have several diagnoses and a possible other discipline referral should be made. For example, right now I'm actually currently working on a kind of very unique caseload. I have a young boy who has 9 different diagnoses, and he was referred to us by his neurologist. And we have slowly, just as Elizabeth was stating, we slowly increased his hours week by week to get up to 40. And even then, that is with sleeping 2 hours throughout the day. And so, due to different illnesses and his weak immune system and what the data that we have collected thus far, the BCBA is actually referring him back to his neurologist to try to come up with a different plan of action for him and his prognosis. So yes, there are absolutely times whenever ABA is not the best fit. And referring back to the Code of Ethics 1.02, boundaries within their competence, if a certain client's diagnosis is not within your education, training, and supervised experience, providing ABA therapy is considered unethical. Done.
Thank you, Ashley. Now we'll have our conclusion.
In conclusion, some questions we'd like to ask for feedback are, what are some facts you learned about ethical implementations of ABA? And were you able to relate to some of the examples provided within the presentation? Thank you for tuning in, and we hope to shed some light on why ABA is or isn't ethical. Can you cut that part out where I was like, done? I feel bad for saying that.